Today is going to be my first Rant podcast. Shame on you instructors and programs for not teaching your people this. Shame on you for not doing your job. Okay guys, thanks for tuning in. So I guess today is going to be my first Rant podcast. Now, as you might expect, something has happened to cause me to rant. And you would probably be right. But I can't think of just one event, really. I can think of a few highlights, but it's been an ongoing problem. And I'm talking about pulse oximeters. So, at first, pulse oximeters work by shining two wavelengths of light, like infrared light, through a fingertip or an earlobe or whatever wherever you're measuring it at, and it measures how much light is absorbed by the blood, and then the device calculates the oxygen saturation level based on the difference in absorption between oxygenated and deoxygenated hemoglobin. So that's a whole lot of technical speak for, essentially, we're just watching the blood go through the tissues and determining how much oxygen is attached to the hemoglobin. Now, a quick Google search, if you're interested, about pulse oximeter accuracy will tell you that most FDA-approved devices are accurate between 2 to 4% of the actual SpO2. And that might be true. I don't doubt that in cases where it works perfectly. But here's the issue. How many times does it work perfectly? This is the thing that drives me absolutely insane. So there's so many factors that contribute to how well pulse oximetry picks up. If their fingernails are painted, if their finger is dirty, if they're cold, like the elderly. Elderly will usually be their fingers are cold, they're cold all the time, or they have a peripheral issue with circulation, so they have decreased circulation. There's so many factors. Movement, patient movement is a big one. And although we do have some advantage, the healthcare providers that use monitors with the attached pulse oximeter, because we can see the pulse wave. So that way we know if what it's picking up actually has an associated pulse or heartbeat. But with the finger type, you don't have that luxury. So what we're getting into is these providers, and it's not just limited to EMS. It's all healthcare providers. We're not teaching these people that pulse oximetry should not be a definitive finding for hypoxia. That shouldn't be the go-to first line, be all, end all to tell you they're hypoxic. There is no replacement for a good assessment. I don't care what anybody says. Not to sound like an old fogey here, but as the younger generation says, come at me, bro. I'll fight anybody over this. I've seen it too many times, and it makes me insane. So a good assessment, let's talk about that. A good assessment, when you come into a patient that you suspect has a respiratory problem, the first thing that we want to do is a good, look over the patient. Look at the face. As you scan down the face, are they breathing with pursed lips? Do they have cyanosis around the lips? Do they appear tired? As you move down, do they have JVD? And as you scan down the chest, do they have retractions around the collarbones? Retractions around the rib cage? Are they struggling? Does it look like their work of breathing is just really difficult? And as you get down to the peripheral checks, look at their cap refill time. Are their nail beds pale, or are they cyanotic, or do they have a good return? Skin color. Are they pale, diaphoretic, or are they normal temperature? Like when you feel for a pulse, do they feel cold or do they feel warm? All these are parts of an adequate assessment. So, for some reason, and shame on you instructors and programs for not teaching your people this, RNs, LPNs, EMTs, paramedics, everybody, shame on you for not doing your job, because you're not teaching your students what they need to know about this subject. Um, it just blows my mind. So, you know how many EMTs that I have precepted recently, or had clinical time with, and they slap a pulse ox on somebody, it reads in the 80s, and they freak out, and the first thing they do is reach for a nasal cannula, and I'm having to say, stop what you're doing, check the patient, look at the patient, not the equipment. Pulse oximetry should only ever be confirmation for what you already know from your assessment. I said what I said. Now, aside from the pitfalls we've already discussed earlier, it also takes pulse oximetry up to a minute or more to register changes. So if you're depending on your pulse oximeter to tell you if a patient's crashing, you've already screwed up. You're already behind the 8 ball. That is not the way to use this equipment. Your assessment, your ongoing assessment, is how you keep track of this. And I'm just gonna tell you a story about this that happened fairly recently. So we get a call. It was fairly late at night. We get a call out at a local SNF. So if you don't know what a SNF is, that's a skilled nursing facility. And we go out there. It's for respiratory distress, and in the CAD it says pulse ox levels are in the 60s. And I'm like, okay, well, knowing what I know already about the issues with pulse oximeters, I'm kind of skeptical. But you don't want to, like, the one time that you don't come prepared is when it's going to bite you, right? So we get there, we grab our airway equipment and our bag, and head in. And I'm thinking, okay, well, I'm getting ready to treat COPD or CHF or something. So we walk into the room, and this patient is sitting up in the bed, just looking around, like watching the show, not really sure what's going on. And as we step into the room, there is an LPN and 2 CNAs standing there by the bedside. They immediately start into their report. Well, this is so-and-so. She's such and such years old. We did our routine checks, and her pulse ox is like, I can't get it out of the 60s. One time it read 80 something, and then it's just been low. It's been low the whole time. And I look over at this patient, and she's got a nasal cannula in her nose, and you can audibly hear it whistling, like from the doorway of the room. So they've got this lady cranked up on oxygen. I'm like, okay, let's see. So I start down the patient, my assessment, pretty much the door to patient assessment as I'm walking up. And she's not labored, good skin color, no cyanosis, work of breathing's normal, good chest rise and fall, no issues. So, I'm trying to be tactful, and I ask a couple of questions. And my partner, love his heart, is the most blunt person that I've ever met. He looks at the patient in front of the staff, and he goes, "Sweetheart, are you having trouble breathing?" And she looks at him and shakes her head. She goes, "No, I feel pretty good." And then he looks at the LPN, and it was like, shrugs his shoulders, like, what is happening right now? And of course they get mad, and it was kind of a hilarious scene. if it wasn't for this being such an issue, what it ended up being was the patient had a peripheral disease, a problem with circulation. And you reach down and feel her fingers, and they felt like ice cubes. So we had her put her hand under the covers and let it warm up for a few minutes. Stuck the pulse ox on her, and it read like 94%. And I'm like, there we go. You know, she's not actually having trouble breathing. So what we ended up doing was we took her anyway for other unrelated issues. But the breathing problem stemmed from just a blatant misunderstanding of how pulse oximetry works and how to properly use it. So listen, if you're CNA, LPN, RN, new provider, whatever, listen to this podcast, for the love of all that's good, please understand, study this and understand how a pulse oximeter works, and stop using it for definitive findings of hypoxia. Now, obviously, CO2 would work better in some cases. You know, if you're looking for bronchospasms and things like that. Of course, always use your end-tidal CO2 for tube conformations, even in supraglottic airways and things like that. But, I mean, CO2 has its own set of pitfalls in certain circumstances, but it's a whole lot less, and it's a whole lot more accurate than pulse oximeters. But, like anything else we have in the field, it is still a diagnostic tool. So please, if you want to be a good provider, you want to catch problems early, you want to be good at your job, there is no replacement for a good assessment. So anyway, that was my rant for the day. I had to get that off my chest. I know this is kind of a shorter podcast than I usually do, but I felt that information was important. So if you like the content, go ahead and subscribe. If you're a YouTube listener, follow on Spotify, and get notifications for new content. I'm going to continue to work on this, and I've got other videos on YouTube in the works, YouTube Shorts, Facebook Reels, a lot of good things coming up. So just to need a little time to get off the ground, I suppose. But thanks for listening. I'll catch you on the next one.